Hello Gordon, Chris Coetzee. I'm really sorry that Linda and I could not join you in Lake Como and in Milan. That would have been fantastic, but that's unfortunately life. So we'll talk about approach and pearls to internal bracing. Again, this is for me always an interesting comparison if you think about femur fractures. When I was young, at least, I'm one of the older guys, we still treated femur fractures and Thomas splints, and then progressed to intramedullary rods and changed the whole history of femur fractures. For me, the internal brace is the same what you and Arthrex did for ankle ligament management equals the really impressive stuff that was done for long bone fractures. We know that the gold standard for ankle is the Brostrom. The question is, can we make them return quicker without compromising the short and long-term result? And it's one thing to say, well, we have this fancy new device, so you can do that. But the only way to convince people to do that if there's good research backing that. And we published this in 2018 with the help of Arthrex. And since then, there's been multiple studies to confirm the success rate of augmenting Brostroms with an internal brace. And we did a really good study here looking at functional results. So this was not just a simple outcome score, also looked at functional results. And we could prove that with an internal brace, we could safely accelerate the rehabilitation process, and they got results that could get them back to participating in sporting activities. So this is the question at hand. So landed bilateral severe inversion sprains, and how do we deal with that? So some of the pearls is, again, if you look at the anatomy, that is always important to see when the ligaments are tight. So we know that in dorsiflexion, the anterior talofibular ligament is lax. In plantar flexion, it is tight. Opposite for the calcaneofibular, you can see in plantar flexion, calcaneofibular is loose, and dorsiflexion, it's tight. So it's important to keep that in mind when you think about your surgical repair and how you tighten your brace. Next for me is the timing of surgery, which changed over time because of the internal brace. The question is always, do you do it acutely, subacutely, or wait for chronic instability? And that depends a little bit on the situation, which could include the age of the patient, the level of activity, and the time of the season. People with open growth plates, I do my best not to treat surgically, and also try not to cross the growth plate if you have to do surgery, because you obviously don't want to create a problem. Level of activity, so if you think about a gymnast or a ballerina, by design they have loose ligaments. That's the way that they can do their sport. So you have to be careful not to jump the gun and do surgery on them too quickly. I have a lot of gymnasts that have very loose ankles, but they manage to do their routines with proper training and rehabilitation, and we know at some point, once their careers are done, you might have to tighten the ligaments to give them a good ankle for the long term. While the opposite is if you have a basketball player or a soccer player or a rugby player, they need the ligaments stable to play their sport. So with them, I will be more aggressive to treat it surgically if there's a complete disruption. If it's a grade 1 or 2, it's still always non-surgically. If it's a grade 3, it's an individual decision whether to treat them acutely with a repair and then augmentation. I often get the question whether to scope or not to scope. For me, that's not a question. I don't do my Brostroms arthroscopically. I have nothing against the arthrobrostrom. I just do them open. But I scope every single ankle that I do a Brostrom on. And it might mean that in about 5 or 10% you do a scope and there's nothing there, but in 90% you can either remove a lot of heterotopic synovium or hypertrophic synovium and loose bodies and other pathology that might help them to recover quickly. So if we look at the surgery specifically, this is a typical case of a chronic instability. You can see, you cannot see any ligaments. It's just a bunch of scar tissue. In this situation, if you open the ankle and you see the anterior talofibular ligament, clearly you know you're in the wrong spot because it was not torn. Also important, I did show it well in the video, but I always want to see the peroneal tendon. It's very easy on the posterior aspect of this to actually visualize your tendons, and if you need to do something, then you can just extend the incision. There's always this soft tissue buildup in the lateral gutter with a chronic instability, and you need to remove that and freshen up the fibula a little bit. You can do this, like I show here, through the ligament, which I think is the best way to do it, and you have to be at the footprint of the anterior talofibular. So make sure you know where that ligament attaches, right over the corner into the cystentaculum, and your drill direction is about 20 degrees off the floor, and you basically aim for the posterior aspect of the posterior malleolus. The brace should be extra articular, so over the soft tissue, not under the soft tissue. When you try to, or when you start to turn this, you can feel that nice squeaky feeling, and you know you're in bone. If it doesn't squeak, the bone is either very soft or you are pushing it into the sinus tarsi. So always test it, make sure you're in bone. And you can see at this point I have not done my brostrom. I do my second drill hole, and this should be at about a 45-degree angle, because the one thing that you don't want to do at this point is to enter the joint. So in a direction where you know you will not enter the joint, you will not enter the posterior aspect of the peroneal tendons or go into the syndesmosis. And then this was a soccer player, so I have the ankle at about 90 degrees. Make sure it's not too tight, but definitely not too loose. I think too loose is worse than too tight. I think over the years I only had two that I thought after the fact might have been too tight, and we can talk about that in a moment. So then mark it where you want to be just before you start to turn it, test it again, make sure you like the tightness of it, and then you can suture it in. So at this point, again, this is more for maybe the American audience in the surgery center. We have to pay for everything that you use. You can obviously do your brostrom using extra anchors, but if you think about it, you have this very nice strong suture that is in the anchor itself. So instead of drilling more holes and using different anchors, I just use that to further repair the ligament. So I'm testing it to make sure, and now I'm actually doing the brostrom, and you can decide the direction of your suture. So if it's mainly anterior talofibular, you do it like I do here, more anterior. If it's calcaneofibular, you can do it more over the calcaneus. And you can see how nicely I can pull that flap of soft tissue onto the fibula and then just suture it in place. It gives you a very nice strong repair with the brostrom underneath the brace, and it gives you excellent stability. I don't know if this is a poll or just common sense, but the rehab program is exceptionally important, and you can read through this, and it's also on our web page. But the biggest thing that changed for me over the years is that I became more and more aggressive with rehabilitation. And it's not cavalier aggressive, it is research-driven aggressive. Of course, we know from the studies that we did and continue to do that the internal brace really works like a seat belt, so you can push the recovery without compromising the repair. And there are a subset of patients, if you push them too hard too soon, they swell too much, and on those you back off. But my current protocol now is they're full weight bearing from day one. They can use crutches until they're comfortable, but I advise them to try and be off crutches within a week, because we know from old studies that weight bearing is good for ligament healing. And that just brings me back to a point I said before about the tightness of the brace. Again, I can recall 2 that I made too tight, so where they could not plantar flex to 90, and we leave it there for the first 6 months. You want then your brostrom to mature, and if after 6 months you still think the brace is too tight, then you can make a very small incision and just cut the brace. Usually just put a band-aid over it, and that allows them to regain full motion, and by that time your brostrom is mature. But again, out of thousands, to do 2 or 3 that again convince me that you can make them a little tighter is better than a little too loose. And then back to the rehab. At 2 weeks they go in a boot and they can be full weight bearing again, and start physical therapy 4 weeks after the initial surgery, and then they basically progress as quickly as they feel comfortable. We always give them this rehabilitation protocol so that they know where they should be at every interval. So how did it change my practice? Again, pre-internal brace, I did about 50 brostroms a year. Post-internal brace started slow after Arthro London in 2012. First for failed brostroms, and then over time it increased in 2021, and 95% of my brostroms are augmented with an internal brace. Did 214 in 21. Last year did 236. So that's a huge number of augmented ligament repairs. And obviously if you do that many, it means that people send their patients to you, and on the flip side, they get good results. Otherwise, they will not continue to come back or send people. So what are the uses outside of lateral augmentation? I used it now for deltoid, acute or chronic, for spring ligament, for posterior tibial tendon augmentation, and for anterior inferior tibiofibular ligament repair, which is in my mind the next new exciting avenue that we're going down. I know people use it for Lis Frank. I'm not brave enough yet for that, but maybe one day. So this is an isolated deltoid. It's uncommon, but if it happens, it's always surgical. And if you look at the MRI, there's obviously a complete disruption of the superficial and deep deltoid. And if you see that, it's surgical. These do not do well with non-surgical treatment. And you can see on examination and the fluoroscopy, it is very unstable. Basically do the same as lateral. You should do brostrom repair in an acute situation. You can either use anchors to suture it back, but I believe in augmentation of them as well. And if it's one like that with superficial and deep, I have 2 arms to the repair. So I start with the first anchor in the sustentaculum of the calcaneus, and then go to the medial malleolus. So that's for your superficial deltoid. And then from medial malleolus, you take the remnant of the suture and bring it into the neck of the talus for your deep deltoid. And as I showed before with the lateral brostrom, then you just suture the ligament in a pants over vest fashion. This was that same patient a year later. This is maybe not necessary to show, but fun. That's him, number 12, and you can see that's a guy that has absolutely no issues with his deltoid. So just finally, quickly about the internal brace for anterior inferior tibiofibular ligament as part of the syndesmosis. You can see this one is very unstable, so you do your brostrom, you need to do a deltoid ligament repair as well. But if you think about the tightrope, if all the initial critique or negative studies showed that if you externally rotate your foot, that it still opens up in the front, which I think was true, and that's why we immobilized them for a longer time. This was one of the US hockey players just before the Japan Olympics, and unfortunately a clear syndesmosis injury, and posterior inferior tibiofibular ligament is intact, but the anterior is open. So it's basically an open book type injury. The fluid in the back of your ankle just confirms that it's a significant syndesmosis injury, and then did the 2 tight ropes, but then added that anterior inferior augmentation. So different ways to do it. You can do it an atomic way where you put 2 anchors, one at the footprint each of the anterior inferior tibiofibular ligament. What I did at this time was to bring one of the tails of the tight rope, and basically just bring it over the fibula and put another anchor into the tibia. And she skated 4 weeks later, and she played every game at the Olympics, which was amazing. A bit scary, but as the tournament went on, we realized that she's fine, and she actually sent me a nice thank you note afterwards, and she's still playing for the Olympic team. What made this story even more important at the time, and you obviously don't know the future, so we didn't know this was going to happen, but the US captain had this very significant injury. You can see where her foot is there. She had a Weber C fracture, and she stayed at the Olympics. She obviously couldn't play, so I did a fixation about 3 weeks later, which was not super easy, but the same idea. And sometimes, like I say, the season helps you a little bit. This injury was at the last game of the season, and that is syndesmosis, and you can see the circle there where the anterior inferior tibiofibular ligament fixation was. And when training camp started next year, he was as fast as before. So the undisputed poles, it is hugely beneficial to my sports practice, and I have absolute complete confidence in the surgical procedure, the rehabilitation program, and the return to play timeline. And the incidental benefits of this is that it created amazing teaching and also learning experiences and opportunities, and could spend time with intelligent and fun people like all you guys, and learn a lot. And I hope you guys have a fantastic meeting.